The second part of the POI, premature ovarian insufficiency, we will discuss the treatment. The hormonal therapy in POI, the principles and indications. The hormonal therapy is recommended. The hormonal therapy is recommended for women with POI until the usual age of menopause for primary prevention to reduce the risk of morbidity and mortality. That is, the morbidity is the cardiovascular disease, stroke, and whether there will whether very important statement here, if there will be estrogen deficiency or present or absent, irrespective of estrogen deficiency is present, irrespective of this estrogen deficiency, you have to start HRT to reduce the morbidity and mortality until the usual age of menopause for primary prevention, reduce the risk of morbidity and mortality, whether there is a estrogen deficiency or deficient symptoms or not. Estrogen deficiency symptoms or not, regardless of the symptoms or not, you have to start HRT. That is the formula. Women with a POI should be advised that HRT is recommended for the treatment of symptoms due to low estrogen concentrations. The guidelines recommend that women with POI reach the age at which usual menopause occurs. They consider the need of continuous HRT based on a personal risk benefit assessment, current evidence. Okay, the guidelines recommends the women POI that hormone replacement doesn't provide contraceptions. You should not tell that if you are taking HRT, it should not that you will not get pregnant, because some of non-iatrogenic POI, the chances of conception is low, but there can be a pregnancy chance will be there. So in order to assist with them, we have to do family planning in that cases. In women with POI with evidence of intermittent ovarian functions desiring natural pregnancy, the recommendations is HRT remain unchanged and don't impact the chances of natural conceptions. So sequential regimen is recommended. So whatever, if they are a POI with evidence of intermittent, they have a chances of intermittent ovarian function, they want natural pregnancy, so you can start HRT. That will not change, that will not impact also in the natural conceptions also. So in that case, sequential HRT regimen is to continue. What are the risks of hormone therapy? Women with POI can be informed there is no evidence that the STs increase the risk of breast cancer compared to women with same age without POI. But you should not recommend, but it is not recommend those which have a history of breast cancer. If there will be a history, so should not recommend, not give. When BRCA1 BRCA2 mutation hai, but very important, if there will be a BRCA1 or 2 mutations, but absent personal history of breast cancers, no personal history, negative personal history of breast cancers, that patients, if you give an option for risk reducing salpingo-oophorectomy because of BRCA1 BRCA2, in that case you can give HRT. Okay, so without personal history of bilateral, HRT is an advised options for those patients with BRCA1 or 2 mutations but doesn't have a personal history of breast cancer. Without have a personal history of breast cancer, should be advised that HT is an options after risk reducing salpingo-oophorectomy. Okay. Another statement, progestogen should be given in combination with estrogen therapy. All women with intact uterus, everybody is know. To prevent endometrial cancer, everybody should know. If there was a uterus, means the progesterone has to be given to the patient, or else there will be chances of endometrial cancers will be increased. The guideline recommend the dose of progesterone has to be increased with a higher dose of estrogen therapy are used. The guideline group recommend that in women with POI with any woman using ST, if there will be unscheduled bleeding you should go for assessment. Okay. If HRT patients, if there will be on HRT and they have a unscheduled bleeding, then you go for evaluations. Okay. The guideline recommend that history of endometrium. Now this one point is very important statement. You have to, because suppose this, I will explain this. Endometriosis, you go for a surgery, you do TLH or TH, whatever you want to do. Then after that, now what will things, there will be no uterus, so you will not give progesterone, but not, this is a wrong statement. So if to for prevention of recurrence of endometriosis, you have to give both estrogen and progesterone therapy to prevent the recurrence of endometriosis or malignant transformations. Even after, very important, even after hysterectomy, this treatment has to be there. Okay. Another things, migraine, they're told migraine should not be used, considered contraindication. Now they're telling migraine is not a contraindications. Migraine, now telling the migraine, if the patients have migraine, what will do? Migraine also is not a contraindication. You can give not a contraindications for HRT, but the statement you have to read, the consider changing dose if there will be a migraine. Okay, but during HRT they have a, during if migraine, during if they have a migraine, you start HRT, you started HRT, but during HRT the migraine if worsen, then what will do? If migraine will worsen, you will change the dose, or route of administrations has to be changed. Okay, so that's what they tell. The consider changing dose, route of administrations if the migraine worsen during HRT, and migraine should not be considered contraindications for the HRT treatments. And very important, another statement, the route, the migraine hai plus patients have visual aura, that means hallucinations, translations. In that case, if aura is there, then should be advised not to take oral routes. You have to give transdermal HRT. So these are the statement you have to remember, because they can ask any form of questions in their exam. That is maybe the lowest risk of route of administration. So these are the statement you have to options. What are the options for hormone therapy? The guideline recommend the said decision making with prescribe each component, and preference, consider patient preference, contraceptive methods, needs, presence of community, different estrogen personal variable metabolic effect. So it has the compound bioidentical preparations. Okay. Next statement, the role of testosterone therapy. Already I told the testosterone should be considered in with iatrogenic POI to maintain a manage hypoactive sexual desire, whether when the other biopsychosocial etiology are excluded. Treatment could be considered with non-iatrogenic to manage hypoactive sexual disorder when other biopsychosocial are excluded. Okay, then should be aware that you can consider, this is the conditional treatment. Iatrogenic you have to consider, should be considered, could be considered, is non-iatrogenic. The should be, although short-term treatment with transdermal therapy, approximately psychological experiment level is safe, longer-term safety data lacking. The guidelines recommend the POI are informed that the limited data androgen treatments for indication other than hypoactive sexual desire. Only they have a evidence that if you have a hypoactive sexual disorder, hypoactive, that is loss of libido, sexual disorder, then you can give HRT for those patients, like not HRT, like testosterone therapy, like transdermal testosterone therapy, that will be effective. Whether it is a iatrogenic or non-iatrogenic, it could be considered, or it should be considered. And but other than this, other androgen treatments not needed, other limited data for indication other than hypoactive disorder. The specific consideration, very important, the specific consideration like guideline recommend risk benefit of the iatrogenic gynecological breast cancer treatments. Actually now those treatment options for iatrogenic POI after gynecological breast cancer, like HRT is does not increase the, what are the effect on the other cancer like breast cancers and the squamous cell carcinoma, cervix, adenocarcinoma, and your ovarian cancer. Actually the hormone replacement therapy is does not increase the risk of squamous cell carcinoma of cervix, okay, recurrence of squamous cell. So it is recommended for women with iatrogenic POI due to your treatment of squamous cell carcinoma, you go for oophorectomy. Then hormone replacement may be associated slightly, very important, you get a slightly, but it's no risk, increased risk in squamous cell carcinoma, but not risk increase, but it will not increase. But in the case of adenocarcinoma, will slightly increase the risk of cervical adenocarcinoma. Personally, this approach has to be individualized, risk benefit has to be recommended. Another things, in iatrogenic POI due to early stages of low risk of endometrial adenocarcinoma, there is no evidence that it increase. There is regarding endometrial CA, there will no increase in increased risk of recurrence. Okay, the iatrogenic POI due to the epithelial ovarian cancer, you can consider HRT. The effect of hormonal replacement, the risk of recurrence in non-epithelial ovarian cancer is uncertain. Okay, but if it is the epithelial ovarian cancer, in a epithelial ovarian cancer, the risk of recurrence is not there, so you can consider that HRT in epithelial. HRT in epithelial you can give, but HRT in non-epithelial, it's uncertain. The road of different of the ovarian recurrence risk of non-epithelial is uncertain. It suggests that as personally approach to be prescribing consideration tumor hormone receptor study up to see the hormone receptor status of the patient, whether estrogen positive or estrogen negative. Based on that, non-epithelial you start HRT, non-epithelial ovarian cancer. Next is ST should be avoided. Very, very important. You know, it is hormone dependent. If it is a hormone dependent ovarian, estrogen dependent tumors, or like thicoma, fibromas, like these are the like ovarian uterine tumors like sarcoma, endometrioid carcinoma, because this is the estrogen dependent tumors, ovarian clear cell carcinoma, clear cells, and granulosa cells, sex cord stromal tumors, granulosa cells, sex cord stromal tumors. So in that case you should have, because these are the hormone dependent tumors like ovarian dependence, hormone dependent tumors like ovarian or uterine tumors like including uterine sarcoma, endometrial carcinoma, ovarian clear cell carcinoma, ovarian granulosa cells, sex cord stromal tumor. These are the hormone dependent. You should not start a HRT in that cases. We should avoid it. So basically is uterine sarcoma, endometrial carcinoma, clear cells, granulosa cells, and sex cord stromal. Men should be informed the risk of iatrogenic POI and the risk benefit of HRT before BISO to reduce cancer risk. It recommends the personalized puberty transplantations. Recommends in girl when the POI following hematopoietic stem cells transplantation or other gonadotoxic therapy. Puberty, those patients. Non-hormonal therapy available. So what are the options? Like peri and postmenopause or the non-hormonal therapy. They recommend that in care about the complementary therapy in common individual patient therapy should be, there is insufficient evidence like Chinese herbal medicines for the management of menopausal symptoms, metal risk, and further evidence which inform the limited evidence on the effect acupunctures of menopausal symptoms. There is a limited evidence and not suggested. Women who are considering using other nutrients of the herbal medicines should be informed that there is insufficient evidence to support. Lifestyle management like including physical activity, healthy lifestyle, metabolic heart benefits in general population, including postmenopausal women. Although specific evidence, lifestyle intervention is limited. Encourage to overall lifestyle modification. In what are the household puberty you should do? Puberty should be induced or progress with estradiol starting with low dose at the age of 11. So if it is a premature gonadotoxic, like young age, very young age, then you start at the age of 11 years with estradiol. Gradually you have to increase over 2 to 3 years. In case late diagnosis for those girls with hormone growth is not concerned, consider modify regimen of estradiol therapy. You can go for a oral or transdermal. The evidence is inconclusive. Combined OC pills should not be used for puberty inductions. Very, very important statement. OC pill not to use puberty induction. You have to give a high dose. Okay. OC pill is low dose, so you score to a high dose. The guideline group recommends starting cyclical progesterone after about 2 years of estrogen therapy when breakthrough bleedings occur. Guideline group recommends the starting cyclical progesterone after about 2 years of estrogen. You will give 2 years estrogen therapy to induce puberty. 2 years of estrogen therapy. Then you start cyclical after 2 years. Cyclical progesterone has to be started. Okay, thank you. If you like this content, please subscribe. Thank you all. This is the part 2 of the POI guidelines. Thank you.